Welcome to SLP Nerdcast, where we review resources, literature, and discuss issues related to speech and language pathology. To learn more about us, listen to our first published episode, Who Are We Anyway?
Who are we? That's a big question. Very existential.
Who are we anyway? Before we begin today's topic, we wanted to give you a quick reminder that you can receive a certificate of participation for listening to this podcast that 100% counts for ASHA certification maintenance hours. Just go to our website, www.slpnerdcast.com, click on the episode, follow the prompts to take a quick 3-question quiz, and purchase your certificate. There's more information about CEUs and our services on our website under the How It Works page. That is www.slpnerdcast.com. So now that is done, what are we talking about today, Aim?
Today we are talking about aided language modeling. And preparing for this podcast was pretty eye-opening.
I agree. So for those of you who don't know, I am employed as an AAC specialist, a quote AAC specialist. And as Amy and I discussed this topic further and read some of the literature, I was totally intimidated. I had a little bit of imposter syndrome.
Imposter syndrome is real.
It is a real thing. And I found myself asking Amy lots of questions, needing to go back and reread the articles to define all the different terms. There's so many different terms.
There are a lot of terms
in this topic.
I think also a lot of us in the field tend to err on the side of perfectionism, myself included. And I think there is just this level of discomfort that comes with knowing that you can't know everything.
And there's so much to know.
There's so much to know.
It's really sort of unsettling.
And it can be challenging to keep up on it all.
Yes, especially in the area of AAC where technology is changing all the time.
Technology is changing, but intervention strategies have remained pretty consistent. So when we think about aided modeling interventions, I mean, some of those have been in the literature for many, many years. I think that they've come back up in the literature more recently. There have been more systematic reviews and meta-analyses, and we'll talk a little bit about that today.
And I think that's another reason why we chose this topic, because it is sort of a hot topic.
It is a hot topic.
Hot topic. That was a reference to Hot Pockets?
Yes.
In case anyone has ever heard Jim Gaffigan's Hot Pocket reference. And if you haven't, then you need to go listen to it.
Also,
anyway, moving on. So let's talk about the structure of today's episode. So first, we are going to talk about what aided language modeling is and what does the literature say. Then we are going to talk about clinical applications for this intervention. What does the intervention look like? What are some things to consider when using the strategy? And lastly, we are going to maybe talk briefly about some training communication partners. But that is another really big topic that could be a future episode.
Mm-hmm. And that's another area where there really is a lot of literature. So I think, I'm interested in doing a deep dive at some point in that content, just to refresh my memory.
Okay, excellent. So what is aided modeling intervention?
So I think starting right here is a good source of confusion. If you look in the literature, I mean, there are a lot of different words that are put together to talk about this idea of providing some type of modeling input on an aided AAC system. And when we think about AAC, there are two big clumps that AAC sort of falls into. So
I was going to say maybe we need to define some of those things for those of you out there who are not heavy in the AAC intervention as your regular day-to-day, like the difference between aided and unaided.
Right.
As a reminder.
Starting right there. When we think about unaided communication, we all are using a combination of aided and unaided communication throughout our daily practice and interaction with others. So unaided communication is anything that doesn't require something else external to your body. So that would be gestures, facial expressions,
speech,
oral speech,
obviously.
Speech approximations, and then aided systems.
Sign language.
Sign language,
yep.
Yes. You need to have a thing. When we're thinking about aided, there's some thing. So if that's written communication, you need some type of writing implement and something upon which you will write. Texting, you need a phone. Typing, you need a keyboard. Symbolic communication, you might have a speech generating device or a low-tech paper-based system or a mid-tech tool. So all of those are an extra thing that you have to carry around with you.
And you have found some really good online resources to point our listeners to for this in terms of the ASHA practice portal?
Yes, at the ASHA practice portal. So I am still learning my way around the new redesigned ASHA website. I don't know.
It's immense.
It is. And some of the things that I used to know where they were and what they were called, I feel like the knowledge and skills documents have now sort of merged into this practice portal. So for those of you who are also having trouble navigating and finding some of those documents, the ASHA practice portal for augmentative and alternative communication has a lot of really helpful resources where they break down different types of AAC systems. They talk a bit about interventions. They talk a bit about assessments. So there's a lot of helpful information on there.
Excellent. So
back to aided methods?
Yes, aided methods. Let's talk about aided methods.
Aided methods. So when we think about modeling, that was my chair. I swear. Look, I can do it again. That was my chair. So back to aided methods. When we think about aided methods and aided modeling interventions, those are ones that involve some type of communication partner input using the aided AAC system. And we remember, aided AAC system is using something external to your body. When you look at the research, it gets a little bit confusing because it is called many different things. Just a couple of terms you might find if you do a search for aided interventions, you might find.
And this is where my eyes glazed over.
A little bit.
Don't tell my employer.
No.
But this was a very, well, I'm self-employed. I guess I can tell myself. I can accept myself for not knowing all of these terms, but this was a really dense component that I think was very intimidating, at least for me personally. Anyway.
Well, and it makes it challenging to know how long these interventions have been in the literature, right? So we can go all the way back to aided language stimulation. That was reported by Goossens in 1989. And then even up to the present day, we see a lot of meta-analyses, which we'll talk a little bit about, in systematic reviews. So that's people who have gotten together and read all the research so that we don't have to read all the individual articles, and they sort of report on the trends for us, which is very helpful. As a clinician who is working during the day and doesn't have time to read all the research. But aided interventions that incorporate modeling have been called anything from the system for augmenting language, augmented input, aided language stimulation, aided language modeling, natural aided language. So there are a lot of terms out there.
And are there differences between these terms? Or is it just that, someone wrote an article in 95, someone came along later in 03 and decided to call it something completely different?
So that was one of the things that came up in both of the big kind of review articles that we read for this podcast. That it's different. Everybody's doing things a little bit differently. And in some of the papers, they're not reporting all the details, so you're not entirely sure how they're using the intervention. So what that means for us as clinicians is that it's hard for us to draw firm conclusions around what is actually best for the individuals with complex communication needs with whom we're working, right? Mm-hmm. So some of these interventions focus really heavily on the comprehension. They focus on modeling one or two words.
Which is something that learning moment, I hadn't considered a lot of, and a lot of my students and clients, and I think that that's a really good point that we'll talk about later. And just for the sake of saying it, when you go to our website, there will be a handout available for purchase, and all of these references will also be listed under the episode description. If you are an ASHA member, you should be able to get most of these articles.
Yes.
Because most of them are published in the ASHA journals. Isn't that right?
Yes, okay. Most, but not all.
But we will have references available on the website.
Correct.
Perfect. So what do all these articles say about this intervention?
Well, they say a lot of different things. So when you look at the research question for each of the different authors, they're all looking at different things. Some people are looking at, does it change an individual's ability to express or understand a specific grammatical morpheme, right? Are we
Does
able
it have
to
impacts on syntax, semantics, social exchanges, all of those kinds of things?
Yep. The other big piece that comes up is the actual groups who are used in the studies. Sometimes the groups who are in the study are people who have typical oral speech. So that's a little bit tricky to translate to the people who you may actually have on your caseload.
I also thought it was interesting that a lot of the research was focused on communicators who have more intact receptive language skills. And I think for those of us using AAC interventions for more complex learners or people who have cognitive disabilities, or people who have low to little receptive language skills, there is not a lot of literature, at least that we know of, on the effects of aided language stimulation on those learners in particular. That's what I took away from it.
Right. And I mean, I remember back in grad school, and you made the same, that, one of the takeaways with research in our field is that the lower incidence your population is, the harder it is to get, kind of randomized controlled studies, because we don't have huge cohorts of people who present with very similar characteristics. We have these very individualized, heterogeneous groups of people, even within a same, diagnostic category. That doesn't necessarily mean that there's much at all that is in common. And I agree. One of the points in the Allen article, Allen et al., which is going to be up at our website, they did a systematic review of the literature and found, a lot of the studies that were in their review that met their inclusion criteria, their subjects had scores on receptive language measures that were low average to 1 standard deviation below the mean, which isn't necessarily representative of...
My eyes just glassed over a little bit. I mean, some of this is so dry. It really is. I mean, I think that there is something very specific about this intervention that becomes so technical.
Yes and no, right? I mean, I've point counterpoint, because I think that what it does for me when I read things like this, it just makes me think about the need to integrate the evidence. So another great resource on ASHA is where they talk about the different levels of evidence, and because so many of our...
Can you tell me a little bit about that?
So when we think...
I am not as familiar with that as you.
Thinking about evidence-based practice, and if you go on their practice portal and look under evidence-based practice, you'll see a lot of information about, sort of the gold standard, which would be a double-blind, placebo-controlled...
20 years of research. Right.
Does that even happen in our field? I don't know. Perhaps it does. I can't recall any studies.
I think that's a medical standard for medication. It's like 20-year studies.
And that's like the gold standard, right?
Okay, I'm sort of making that up. Please don't anyone Google that.
I mean, that might be...
I preface this podcast with I don't know everything, so...
Neither of us knows all the things at all.
Back to the topic at hand, anyway.
Back to the topic. So from there are different levels, kind of in descending levels of stringency of evidence.
Yep.
And clinical experience is part of that. So you should be integrating your clinical experience and expertise, the clinical experience and expertise of your colleagues. That's part of your decision-making process with evidence-based practice. But a portion of that is reading the literature. So when we look at the literature, I think knowing things like that very dry statement about the majority of the studies are, Is
that your nerd voice?
That's also fine.
Can you push your glasses up with your finger when you do it?
Yes.
Can you say it again?
So the majority of studies.
Anyway.
We think about people who are in the low average to less than 1 standard deviation below the mean. As people who administer standardized tests, we understand the mean. We understand what 1 standard deviation below the mean means. We understand what it means to be an individual who's able to participate in a standardized receptive language assessment and receive a standard score.
Right.
So for me as a clinician, that just helps. It's an additional piece of information that helps me know how much and how likely the results of this study may or may not translate to the needs of the individual person that I'm working with.
Okay, so sort of taking a bird's eye view of all of this literature, what does the literature say? In terms of using, and I have to say, for those of you out there who are working with other professionals, I have heard insane things being said about aided language stimulation, like it's not evidence-based practice. And there is a clinician out there who said this at a conference recently, and her name will remain in my thinking bubble. I will not say it out loud, but there is, I don't want to say a controversy, but there are individuals out there who question whether or not aided language modeling is an evidence-based practice. I've worked with BCBAs who have said, oh, but you're just giving them the answer. You're, modeling is a kind of prompt, which is true in the ABA world. So in terms of the body of literature that we've reviewed, I'm going to ask you a yes or no question, and then we'll elaborate on it a little bit more. Would you say that aided language modeling or aided language stimulation or whatever acronym name you want to call it, is it evidence-based practice?
I think they would classify it as with a qualifier, right?
Okay.
So it's not something that is, yes, very clearly evidence-based practice. Everybody should do it because
that highest tier of stringency.
Oh, it's definitely not.
Right.
It's definitely not. But that doesn't mean it's not something that a clinician can incorporate within the construct of an evidence-based practice approach. So just like any other practice, really. I mean, speech pathology is an art and a science.
Oh my gosh, I say that all the time.
And did
you steal that out of my brain?
Probably.
Did I say that to you?
I'm sure you have.
I say it all the time.
I'm sure you have.
That's so funny. I had a professor that said that to me. Shout out to you, Betsy McCucci. You're out there. Good job.
But I think it's so true, that phrase that I stole from your historical mouth.
Historical mouth.
Because when we think about it, it's not a definitive plus minus, right? I didn't swab your throat, and yes, you tested positive for strep bacteria. I should give you these antibiotics. It is, it's a dynamic process. It involves interaction and communication between two people. So I feel like what every clinician should be doing is forming their own clinical questions, collecting data. Teaser. We'll have a podcast about collecting data.
Oh, yeah, we have a data podcast coming up, episode.
But collecting data and then using that data to inform future decisions. So in the constellation of that, I think, yes, it definitely can be a component of evidence-based practice.
So just sort of recapping, it is not the highest stringency of evidence-based practice. However, it is still considered effective, and clinicians should consider using it as a tool in their intervention.
Yes. And you should consider how you're using it. So when you look at those big reviews of the literature and see what they found, some of the people were looking at, does this aided input help with receptive language? Does it help with your ability to comprehend somebody's spoken output? Some of the studies are looking at expressive use. Does aided modeling result in an increase of expressive use of specific vocabulary or, target structures? So form your own question as a clinician about how you think you would like to use aided language stimulation with your client, and think about, you may have two clinical questions. And that happens for me sometimes, as somebody who also works with AAC. You'll form a question and say, all right, I'm curious about whether or not this aided input will help you more independently follow a one-step direction, let's say. Or I'm also curious about, will this aided input increase the likelihood of you using these specific target vocabulary words?
Right.
Or,
And not to do a shameless plug again, but data. I mean, when you're looking at, when you're looking at whether or not that intervention has an impact on those specific variables, you're really looking at how the numbers, how does it impact the output. And I just wanted to go back quickly to something I see. I'm reading over her shoulder here, looking at her notes. The word dosage. That's an interesting word that I don't think I have used often, ever, in terms of my intervention, how much of an intervention I use. I don't know if that was used in the Binger and Light article or not, but in terms of the word dosage, what does the literature say about how much of the intervention you're supposed to use?
Okay, so this was one of the coolest things for me about reading these articles. When I read the Allen article, Allen et al., which was a review of a lot of different articles, they referenced this article from Binger and Light, 2007, where they talked about their aided language modeling intervention, which is one of the names for it. And in this study, they looked specifically at, what is the ideal dosage. So this was very interesting to me.
Have you ever used the word dosage?
I mean, I've used it in
life. No. I mean, like,
I've said that word
training,
before.
No, when I'm training a team, I don't say, okay, so the recommended dosage of aided language modeling is blah, 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 blah. And it's a great word. I really liked it. It was very medical, very clear, cut and dry.
I loved it. I thought it was such a good, it made me think about things in a different way, which is really back to that evidence-based practice. That is why, as clinicians who've been in the field for a bit, it's really great to go back and read these articles because it gives us new ideas and new thoughts about practices that we've already been doing. So,
and just pause for a second. Amy and I have this discussion a lot. I think it's really hard to consistently read literature when you have a full-time job. I mean, going back to the literature is something that we do, I think a lot of people do when they have a contentious situation or they're faced with a client or a student where they're totally lost and they don't know where to go. But when you're using some of these things in your everyday practice, the motivation to go back to the literature is low. So this has been at least for me, a really helpful experience because I don't read literature for fun.
But now you do.
But now you do. I guess I do now. Okay, it's fine. It's fine. I'll admit it. Amy's always saying, that time, when you read an article and then it makes you want to read another article, to which I reply, no. I read a half of an article and then I want to take a bath or go do anything else other than read another article. Except it happened to me just once when we were preparing for this podcast. So anyway, total tangent, but let's go back to the concept of dosage here for a second.
So thinking about dosage, this was a new idea for me as well. And I thought it was very cool. So what they looked at was this very structured definition of what aided language modeling was. And they said, when you're providing aided language modeling, your guideline is you're shooting for at least 30 models within a 15-minute session.
30 models within a 15-minute session. So that's a ratio of 1 to 2. 2 to 1.
Yeah, 2 to 1.
Interesting.
Which
is dense.
Is dense. And I think when I reflect on the aided modeling that I see, that seems most likely to happen in a highly structured and sort of directive setting, which, to disconnect from the literature a little bit, I think there's also this piece of thinking about how you're using the information that you learn in the study. So obviously these guys are doing a formal study. Mm-hmm. I'm not doing a formal study. I'm a general practitioner. I'm a speech pathologist working in the wild. And so
working in the wild.
We don't have the same level of stringency because we're not obviously conducting a research study. So thinking about times in your day, I'm in a school environment. So in a school day or in your clinic setting, if you're outpatient or private practice, are there certain activities where you can approach that density of dosage, and then are there other times, I'm thinking of more naturalistic opportunities where that almost, I'm not sure what that would look like.
Well, it can be cumbersome too. You've got a device maybe or a piece of paper or whatever the materials are that you're carrying around. You might be interacting with an individual who has other complex medical equipment or behavior. I mean, providing that density can be physically difficult and very unnatural.
But I think it's interesting, right? Like,
right.
We think that, I don't even know because I've never had this concept of dosage,
right?
So now with this new idea, it's going to inform the choices that I make moving forward. We learned something new and cool.
We did.
So we're going to try, I'm going to be curious to see what does that really look like. I think the other big piece that they mentioned in the study that I thought was very interesting was that if you're doing a multi-symbol message, so if you're modeling more than one word at a time, or whether that's high tech or low tech, there should be no more than a 2-second delay between reference. Or pointing to reference. So if you're combining symbols, so if I'm saying, I want to go outside. Okay.
Yeah.
Then I'm going to want to activate those speech chunks with no more than a 2-second latency between them. Or if I am working with you and say we're doing some early joint attention work and I am pointing at a referent and then I'm providing you a model on the device, I want there to be no more than a 2-second latency between
when you point to the cookie and say and use the symbol cookie. Point to the actual cookie and then use the symbol for cookie.
And that was interesting for me because it made me think about, back to incorporating your clinical experience, just all of the individual variation and heterogeneity between the people who differences between the people, you know, with whom we're working. Because first, you know, I've definitely had clients where a 2-second latency is unrealistic. You know, you if you have a complex body, you might not be able to reorient.
And again, I also think that it's just becomes a question of management. Physical management, like how are you physically going to be doing this throughout your intervention? So for example, in one of the settings where I consult, the staff carry iPads because they take data on iPads. So they've got their data collection iPad, they've got the student's iPad, they've got the visual supports attached to a lanyard for behavior modification. Joey is, you know, you're trying to prevent him from flopping on the floor. And then you're also being told by the speech pathologist to provide a 2-to-1 ratio of aided language stimulation
within 2
seconds. I mean, that can be that's a real challenge. I mean, that presents itself with some logistical challenges.
Yeah. Yeah. I think it's important to incorporate all of the variables that you know about your environment, the communication partners, and the communicator when you're making a plan so that everybody can feel successful.
Yes. And enter the importance of an implementation plan, which is probably a plug for another future future episode.
I know. I realized that one thing that we didn't do is we didn't talk about exactly what it looks like. So that's another piece that I talk about a lot with people. I didn't find really clear definitions in the literature, again, because it sounds like there's a lot of variation. What does it look like when you do aided language stimulation? Like, what does that look like for you? Like, do you say the whole sentence and then model one or two words?
Oh, that's a really, really good question.
At the same time?
And I think the answer to that question depends on the language level of the individual I'm working with. So if they're a super emergent communicator, it will, I really can't speak to what quote dosage I'm using because I had never thought of it in terms like that, but I have recommended doing it as often as possible. So presenting them with high rates of high frequency within high rates of a word, using really a potent language, the things that are important to them, things that are really reinforcing, because my population is more of the complex emergent communicators. And I would usually I want to say another ratio of 1-to-1. So like single word, single symbol, single spoken word, and the referent that's available. I think for individuals who have higher language levels, who are maybe using 2-word utterances, I would say, I really don't, I haven't thought about it before. It's probably a lot of the same. I mean, it's probably the same density of verbal to symbol. I think I always say it at the same time. I'm not silent. Is that sort of what you're getting at?
Yeah, I feel like that's something that comes up a lot, and I've given it some thought because as I've provided, consultation and training to different groups of people, it's a question that comes up for me, so it's made me think about it.
Okay, what are your thoughts?
I have noticed, because I've been thinking about it as I'm doing it and trying to better qualify what I'm doing so I can share that information with other people. If it's a low-tech tool, so let's say a paper core board with some fringe vocabulary
with no voice output.
No voice output. I tend to reduce my rate of oral speech. I tend to, like you, I sort of think in terms of Brown stages. So if you're a single word communicator and you're not yet combining into 2-word combinations, I'm typically modeling 1 word at a time, but my oral speech may be slightly longer than that. So if I am using oral speech to say, let's say a 2 to 4 word phrase, I would model the key word or maybe 2 words simultaneously. I tend to do it simultaneously, again, if there's no voice output. If there's voice output, I tend to say it with oral speech and then model the 1 or 2 word combination using the voice output.
Follow-up question. Now, because there is so much variation and from clinician to clinician, and which is good because you're probably making choices based on the individual client that you're working with and their language level and presentation and social tolerance and all of those kinds of things. What does the literature say anything about those qualitative differences?
It's varied. So
Right.
that's the conundrum, and that's why, in part, I think that this isn't a highly recommended strategy because we have a lot of research that's out there, but it's on very different groups of people. People are using different intervention methods. So for me, I try and standardize an intervention method myself because I am working with lots of different communication partners typically who support one student.
So I was just about to say, not to put you on the spot, Aim, but you've been working in AAC specifically for a long time.
A while.
A long time.
A while.
And just as a side note, this episode is about something that Amy and I both do in our jobs. So we have a lot more personal experience to bring to the table with this, and future episodes we may be relying on others for these kinds of things. But in terms of, Amy, your personal experience, what is your rationale for that ratio of saying things more with a light tech tool? Like, is there when you've had that conversation with yourself, how is it that you've come to those decisions?
I would say it's less of an overt choice that I've made myself. It's been more of an observation of what I end up doing.
Okay.
So I've paid more attention to it in recent years because people have asked me questions, and
like this just now, when I put
like
you on
this
the spot
just now,
in the
and
middle of live recording.
And I feel like it's something that, yes, thanks,
You're welcome.
buddy. You're the best. So I think it's we become automatic with different things, and then when somebody asks you how you do it, you have to really step back and think about it.
Well, even just now, when you asked me that question, I'd never thought about before.
But I think that's an important piece of being more effective in working with other people, right? So outpatient, which is where Kate and I met. When you're working outpatient, there's a lot of family involvement, which is one of the things I love about outpatient. And you have families coming in, and you want to help support them in understanding the strategies that you're using with the client so they can follow through. But part of being able to share that information with other people is being able to dissect it down to its most simple components to make it accessible.
Okay.
Right? So in order to make it accessible to people, you really do have to be able to step way back. It's like tying your shoes. I props to all the OTs out there, but I don't know that I could, without explicit thought.
I thought you were going to say that you can't tie your shoes. No. I was like, where's this going? I see you're wearing
the
boots with a zipper. Do you really not know how to tie your shoes? Anyway, go on.
But I don't think without sitting back and reflecting on it, I could tell you the exact steps to tie your shoes. Right? Could I teach you to tie your shoes? No, but it's something I can do.
Right, you can tie your shoes. That's great.
Yes.
Don't worry, everyone. Amy can tie her shoes.
I can. So I think it's the same thing. I think that as a speech pathologist, especially somebody who's been doing something for a while, sometimes we forget that at some point this took explicit thought for us.
Right.
And
totally.
we expect communication partners
we habituate to it. Yep, totally.
And when you expect other people to do something without giving them enough support, it just becomes frustrating for everybody, and that's unfortunate and not what we want.
So the concept of input-output mismatch, what is that related to? That was something that came up in the O'Neill, Light, and Pope article, and I don't know what that is. So
that is another, if you're only going to read 2 articles from this talk, I would recommend the Allen et al. And the O'Neill et al. Articles, which are both big reviews of lots and lots of studies.
I love those. I am coming to love those articles because you read one and not 5, and you get like a really nice takeaway of the bigger picture.
Well, and as a person who's not a researcher, I'm not a researcher. I went to grad school, I read research, I learned about it, but I'm not skilled in research. But I want, as a clinician, to be able to feel like I'm using what's best practice. Those articles are so helpful. So what they're talking about in that article is just the difference between if the expectation is that the client is going to use aided AAC as all or part of their output method. And none of their communication partners are using that as part of their input method, there's a mismatch.
That's the mismatch.
So
right.
when we think about typically developing individuals who are using oral speech, they're
the input matches the output.
Yes.
Right. And I think that's a really important cornerstone of the theory of aided language stimulation, of why you would use it to begin with. So I think there is this, and I have this conversation with BCBAs all the time. Why should I be using aided language stimulation? What is the literature about? You're giving them the model, you're giving them the answer, it's a prompt, et cetera, et cetera. But there is this theoretical component of, well, you want to provide the same language learning opportunities that a speaking child has. And a speaking child has having verbal speech modeled for them. I mean, I have 2 children. I spoke to both of them the day they were born with no expectation that they were going to speak back to me. So, there's that theoretical component of providing the same language learning experience by giving aided input so that you get aided output.
Well, and there's the Jane Corsten quote that I don't have in front of me, but I use in almost every training I ever do.
I don't know that quote.
I'm going to get the math wrong, but it's basically making the point that
I know what you're
somebody who's using oral speech, who's going to be an oral speaker, has received,
10,000 or something, right?
I thought that it was like 4,200 hours or something.
Yeah.
And the mismatch is that in order for somebody who's an augmented communicator using aided AAC to receive that same amount as an 18-month-old child, if their only exposure is, twice a week during a 20 or 30 minute speech and language session, it takes them 84 years just to receive that same level of input. So if you're ever doing a training, look up the Jane Corsten quote, because it's really impactful. And that's part of, whether we have hard data or not, it's something that makes sense. And sometimes things that make sense aren't real.
Well, I was just about to say, but sometimes things that are logical and make sense are a great gateway to get buy-in from the individual's communication partners. And again, this is sort of looping back to our first episode on collaboration. But if you have someone, a parent or another person on the team who doesn't want to use this intervention method, that's, maybe that's okay, but by providing that very logical theoretical framework, it doesn't make it seem like a huge red light procedure of, there's no evidence for it and all of that kind of stuff.
Well, and another big piece that I didn't read in the articles, but that makes sense to me just kind of as a general practitioner, when people are using some type of aided modeling intervention, it also helps everybody recognize what needs to be in the device.
Yes.
Right? So even if you have a very robust device that's filled with all sorts of core and fringe vocabulary, we still probably need to customize it.
Yeah.
And a great way to understand that is through using it.
When Nana goes to find the birthday cake icon and it's not there.
Right.
Oh, wait, we need to put in an icon for birthday cake.
Or Nana's not there.
Oh, poor Nana.
I know. Let's put Nana in the device.
Nana needs to be in there. Everybody loves a Nana.
Right. So there are a lot of kind of operational benefits as well.
So the first half of this podcast or episode, I keep saying podcast, it's an episode in a podcast, has been very literature heavy. And I think it would be a good idea to talk about the implementation. So now that we know that it is a valid form of intervention, there's a big gray area in terms of what it looks like, how each clinician does it. There is varying evidence in the literature on different ways in which it can be beneficial for syntax, semantics, all receptive, all of those kinds of things. I think it would be a great idea to talk about physically what it looks like and what components you should consider when designing your implementation plan using aided language stimulation. And you have a few notes here about ASH's guide to evaluating clinical evidence, which I think might be really helpful in terms of the importance of using existing research as your starting point. So maybe you use some of this literature to inform why you might use your ratio, for example, or your dosage, So then using that as a jumping off point to fine tune things for specific clients. Does that make sense?
Yes. I mean, I think that's what it looks like a lot for me is we read something like one of these systematic reviews of the literature it raises new points, perhaps, things that we haven't thought about, and makes us think about, okay, so how could I modify my practice to see if this is potentially more beneficial to what I'm currently doing for these clients. And so you're getting your information from something that has been somewhat established through research, although as we know, it's not as clear as that. I think what the research tells us is this might be helpful, and we need more research to be done. So knowing that it might be helpful, I think it helps us to form a clinical question around, for instance, when you read the systematic reviews, you find out that receptively, a lot of the information, when you see studies that have shown that it did help the clients acquire a broader range of receptive vocabulary, usually that's looking at single words. But in real life, a lot of my students, it's more naturalistic than that. It's not, can you point to the blah, blah, blah when I also give you aided language input. It's more, can you follow this classroom direction more successfully?
Right, functional.
And so knowing that right away, we know that I'm hoping that this intervention might help in a way that it hasn't really been demonstrated in the literature. So I want to form that question and collect data to kind of get a feel for that, because we also
data.
Right.
I mean, it all comes back to the data.
Well, because we don't want people doing things that are extra work. So I think that that's another thing that sets apart clinically, right? A lot of our interventions, I say all the time, AAC intervention is the same as language intervention. Right. You're just using this tool. I think that aided interventions, aided modeling interventions feel the most different to people because you have to learn this different set of skills.
It's bulky and unnatural. We spent however old you are as a clinician speaking with your mouth. So you have that many years of learning history to communicate with verbal speech. And then all of a sudden you're being asked to communicate a whole different way. You're learning at the same rate as your student a lot of the time. I mean, I think it's a lot about your own behavior change.
And people get uncomfortable about it.
It's
like,
uncomfortable the first time
pressure.
you do it. And I've had that same reaction myself when I started doing this, and I had the same. I've had a lot of parents have that reaction. So thinking, and this is sort of a nice segue into one of the first components to consider when you're designing your intervention using aided language modeling is, what is the environment like? So are you trying to use this intervention in a busy classroom with X number of other kids, or in a classroom with a particularly loud group of other kids? Is there a lot of clutter around? Is it like the classroom I described earlier, where there is extra equipment, medical or educational equipment around that you have to deal with? And how do you navigate through those things? And I think that's a really important conversation to have with the team, to try and find a way to make it, this is an ABA term, but low response effort. You don't want to have, if you have a team that's saying that they are totally overwhelmed by aided language stimulation, you want to find a way to make it seem as reasonable and as feasible as possible, navigating through all of those different environmental factors. And I think you brought up another really good point when we were talking about this before we started recording, about joint attention. So a lot of times I'll walk by a classroom and, one of the teachers or staff members who I've trained is doing this amazing job of providing aided language input. They're, either asking the student what they want to earn for a break, or they're asking a WH question using aided language stimulation. And I look over and the students' eyeballs, they're stimming, looking out the window, or they're not paying attention at all. And my heart sort of breaks, because the staff they're doing what they're supposed to be doing, but joint attention is a huge component to this intervention that I think, at least in some of the settings I've been in, gets taken for granted.
I would completely agree with that. I also think that back to the idea of unaided and aided communication, I think that there's a lot of input that people can provide, and this isn't in the studies that we're looking at aided input, but I also feel like aided communication or unaided modeling, modeling is really important, right? So those early gestures, when we think about joint attention skills form the foundation of communication. If I'm not looking at what you're looking at. If you're modeling something, that disconnect is not going to facilitate optimal learning.
Right.
So there is a piece of, you need to be in the moment together. And that's why for a lot of early communicators, we start with things like requests, because that's what's interesting and motivating to the client. And we all learn best when we're interested and motivated. I mean,
yes.
I'm a medium nerd. I do sometimes read research articles for fun.
She does.
I read them in areas of interest to me, right? I'm not reading research articles on particle physics. No offense to all you particle physicists.
The Wikipedia pages on what's happening at CERN are really interesting. There are multi-universes.
Oh, it's okay. That's good.
But I read that because I think that is really, really interesting for me. But you couldn't make me read anything about, I don't know, the Kardashians. No offense.
Right. No offense.
That's just not my jam. But, they're awesome. They're cool. Not digging on anybody and what you're into. But I guess the point is, you naturally engage with things that you find reinforcing. And that is an incredibly crucial component to your communication partners and your client.
And if you read the literature, they do talk about that. A lot of these aided modeling interventions take place specifically within the context of a motivating and naturalistic routine. So those are pieces to think about, your environment, but also the individual, like who is the individual? And what are the environmental impacts for that individual? Some clients who I've worked with are right there with you, and joint attention is a strength. They're very motivated socially, and so it doesn't matter, if you're at a circus, they still, we're sharing that moment. We're sharing that moment together. We're able to shift our attention together. We're able to shift topics together. And so for those individuals, I think it may still be a variable for the communication partner, but for those individuals, whether you're providing that model in a crowded, busy classroom environment with lots of visual stimulation and movement and auditory stimulation, doesn't matter. For other people, it does.
Oh, right. Yes. I'm just thinking about my own particular students. That's a game changer. I mean, they're not going to be paying attention to whatever you're modeling for them because they're going to be attending to all of the extraneous noise.
So if you're trying to answer back to, we formed a question about is modeling, let's say our question, back to making the question, let's say our question is, does this modeling intervention help our client better follow one-step directions? You may want to collect some data across those different environments and get a feel for, maybe right now at this moment in time, we do see a difference in the quiet outpatient environment, right? So when they go after school, they've had a snack, they're at outpatient, they've got some fun toys and games, we really see a difference. Then we wonder, do we also see that difference in a busier environment or in a novel place? And it helps us better focus the communication partner. Back to what you were saying about, like, don't ask people to do too much. Think about, if we know right now that these quieter times are better times, maybe those are the times we focus on to begin.
Right. So sort of recapping, the environmental variables are really, really important to consider when trying to design an intervention with aided language modeling. Another important variable to consider is content. So what exactly, and this is, I think you said it so well a few minutes ago, AAC intervention is language intervention with materials.
Yeah.
So what is your student working on? What are your language goals for that student? And that should guide, I know we have talked about this dosage with a 2-to-1 ratio of 30 models in 15 minutes.
Yeah.
No,
30 in 15 minutes.
In 15 minutes.
So 2 a minute.
For a second,
roughly.
I got nervous. It was 15 seconds. I was like, no way, that's insane.
So fast.
That's totally crazy. So fast. Just rapid fire, just on the device.
I think then you verge on like socially inappropriate. It becomes weird.
Okay. Anyway, sorry. Scrap that. It is 13 models in 15 minutes. So you're, trying to consider that. Is that single word utterances? Is that a 2-word phrase? Are you working in that student zone of proximal development? Are you trying to provide this target because eventually you want to integrate it into a behavior plan where you're using that as functional communication in the absence of unwanted behavior? What are your goals in terms, your linguistic and functional communication goals for that student when you're designing? I think that's something that's just really important to consider. And something that the teams you're working with or the other collaborators or other communication partners that you're working with might not either have the background information. You might be saying a parent that says, well, I want them to say a full sentence. Mm-hmm. Maybe that's not quite where they are, or the BCBA you're working with, and I always use that example because that's who I work with. So forgive me, but the BCBA saying, well, I want them to use this word because it's part of the behavior plan. Yep. So trying to take inventory from all the different stakeholders, consider what their learning experiences are, what their areas of strength and weakness are, and then deciding on what those content variables are when you're designing and writing it all down. I mean, I think, again, plug for an implementation plan episode at some point in the future, when you have all of these pieces written down and you can distribute it. Because let's be honest, you can provide aided language modeling as an intervention in your pull-out sessions in school, in your 30-minute speech sessions in an outpatient facility. But when you get the communication partners on board, they can bridge that input-output gap.
Well, because then we're back to that Jane Corsten quote,
right?
Exactly. Because if, as the speech pathologist, so for all the speech pathologists who are listening, there really is, and I think that's a piece for all speech-language pathology, but it's particularly true for AAC because of the input-output match, that there is this kind of double burden to really spread what you're doing and make it accessible for all the other communication partners so that client is receiving that input across their day. Mm-hmm. And I have found a couple of strategies, just back to practical implementation. I find, I think back to when I first started working with aided communication and back in the day of much larger, heavier devices, feeling overwhelmed that how do I find the words? And I don't want to look like I don't know what I'm doing, but I don't know where any of these words are in this device.
And they say that's a good thing to model because nobody's ever going to know everything, right? So when you make a mistake, you're showing someone, it's okay to make mistakes.
But it feels uncomfortable in the moment. So
it's intimidating. One
thing that can be helpful is just making a sheet of words, right? And that could be, these are the 5 or 10 words that you're working on this week, and share that with people, because that's going to help people use those words instead of other similar words. So it's nice because your client is getting a lot of kind of auditory bombardment of similar terms over and over again across multiple environments, communication partners, and we like that because that's consistent input. And it gives people a little bit of permission to just focus on a few things and feel a little less stressed out. Sometimes we even, print out the actual icon sequence. Like, you're going to press this button, this button, this button.
You have to meet the communication partner in their zone of proximal development. So, making sure that you're breaking it down into more consumable, less, stressful pieces for them.
Because back to working out. Right? I want to work out. If somebody came to me and said, I need you to work out, we're going to start with running a marathon.
Right.
It's just, it's not going to happen. But if somebody said, okay, it's the whole couch to 5K thing, right? We're going to walk. We're going to walk a lot. You're going to run a little bit. We're going to walk. You're going to run a little bit more. We're going to walk. You're going to run a little bit more.
Right.
That's basically what we're doing with communication partners. I find that to be more successful and just feel better too. Then people feel positively about it. You're more likely to do it next time. It's not this thing that makes you feel uncomfortable and like a failure.
So, just again, recapping, providing a written plan to people can be really helpful. Making the list of content, or writing down the content that you want them to work on. So maybe just pick one word, pick a small number of words, show the communication partners where those words live so that they don't feel like they have to find them on the fly. And I also think giving some boundaries around where someone can or when someone should be doing this. So I've had parents say to me before, I can't possibly do this all day long. I cannot provide aided language input all day long. And I know you're telling me that that's what's best for them, but I can't do that. And they just shut down, and it's totally stressful. And so, home environment's really busy. They're totally different than every other environment that child or communication, the student is in. So giving them parameters around when they could try. So meal times tend to be more structured, or maybe the family has a nighttime routine that's very structured. Talking with the family about what parts of their regular life they feel that they could include it at a small, reasonable amount without totally shutting down and, feeling like it was way too overwhelming.
Well, and I think you make a great point about, I noticed that you didn't say give them an activity that they can add into what they're doing. You said find out what they're already doing.
Yes. Because I used to, before I had my own children, I would make these insane recommendations to families. And now that I'm a working mother of two, I think if somebody told me I had to do something, I would punch them in the face. I don't want to do that while I'm cooking dinner, everything's burning, the kids are screaming at each other. And these parents, they have a child with a communication difference. And so they're already dealing with a lot of other extra things. And we know that their stress levels are higher.
And we know that they also eat dinner.
Yes. And
everybody's eating dinner.
Right. So talking to them about what they think, and this is just a counseling component, what do they think is reasonable for them instead of telling them what they should do. And I think, go ahead.
Oh, I wanted to get in. We've talked a lot about using aided modeling interventions and sort of the impact receptively, and in part so what a person understands instead of what a person is saying. And a part of that is because one of the things that came up in the Allen et al. Article was the mismatch, right? So, and I've seen this happening. I see it sometimes in goals and objectives, regardless of the setting. If somebody who's using AAC for expressive output for all or part of their expressive output, sometimes you see goals and objectives that are only expressive. And unless that person has receptive language skills that are completely within normal limits, we as clinicians need to be mindful and aware that that's a really important piece. Just because we're focusing on your expressive output, and obviously we want the most, the highest degree of expressive communication possible for all of our clients, receptive language is super duper duper important. So it's really important that we're working on that. And I think that was a big takeaway for me. We really should strive to keep it balanced. So back to, it is really just language intervention. It's language intervention. If you had somebody come to you with a significant expressive deficit and a receptive deficit, you would not only have expressive goals for them, you would have expressive and receptive goals for them.
That's a very, very good point.
The other awesome point raised by that article was just the potential impact on grammatical output expressively for that individual. So thinking back to the amount of input that oral speakers get at a young age, when we think about Brown stages, I think it's Brown stage 2 starts the early acquisition of the morpheme ing. So if we're having somebody who's working on oral speech, we're working on the inclusion of that present progressive marker. Are we also doing that expressively for our individuals who are at a Brown stage 2? So just
making sure there's still that connection between language intervention and what we know about language development, and it shouldn't be any different because you're a device user.
And it doesn't always follow. There are definitely differences. It doesn't always follow the strict developmental hierarchy. And I know that there's been I heard a couple ASHs back, I guess there was a talk about Brown stages and whether, how much those are applicable to typical development. But I think, we referenced the Rhea Paul book, like that inside cover of the Rhea Paul book.
Oh my gosh, yes.
Just acquainting yourself with, oh yeah, that's right. This is also happening. This person's skills are clustering around a 24-month level expressively. We should be working on this syntax and grammar component as well, not just vocabulary. So I think just keeping all of the pieces and not letting all of those other pieces of language intervention fall off your radar is important.
Yes, totally. I think those are really great points. And I think the only other thing, just looking at the time, we did want to touch a little bit on partner training and different strategies for partner training, which is a massive, massive, massive topic in and of itself.
Yeah.
But are there tiny bits of information that we can loop into aided language modeling? I know we've talked about it a little bit in terms of making sure you're taking into account what the communication with the stakeholders, what they value, what vocabulary is reinforcing for them. But training people in how to use aided language modeling is a whole ball of wax.
It is. I think it's certainly a talk for a later time. I will say I was hopefully, how I am I'm sort of a fangirl for certain people's research, so that's pretty nerdy right there.
Fangirl.
But there was a while that every time I went to now I can't even say there was. It's still happening. Anytime that I go to a conference and Jennifer Kent Walsh or Kathy Binger are speaking, these people, you don't know me, but I'm always there. I go to see them because they do such great work on partner training, and it was an area. In my current role, I'm consultative, so I'm working always to do a better job with this piece. And so I read a lot of their research, and I thought, oh, they did a great job. They broke down all these pieces. They're awesome. So they are awesome. Jennifer Kent Walsh, Kathy Binger, look them up. They do great work.
And I think this is a shameless plug for a future episode on partner training. So stay tuned for that. We will also put up a few links to some resources related to that, since we talked about it a little bit. And that way, if you're dying to learn about it before we have a chance to get an episode together around partner training, you can do your own research, do a little bit of your own nerd reading. Why not?
Talk them at a conference, but not in a creepy way, just like a you want to learn the things way.
Oh my gosh, that's really funny. So just to sort of close up shop here a little bit, as a reminder, you can go to our website and find this episode, www.slpnerdcast.com. You click on the episode and follow the prompts to take a 3-question quiz and purchase your certificate. There is more information about us and our CEU process and what services we offer on our How It Works page. The website is www.slpnerdcast.com. Again, just in case you didn't get it the first 40 times I said it. And thanks for listening.
Yes, thank you.